Hello everyone, my name is Philp. I'm a clinical physiotherapist and a researcher. In this video I'm going to be talking about a study we recently had published, and as a part of this video I'm going to cover some biomechanical principles which are relevant to understanding the paper in a bit more detail. There's more information around how you can access the paper at the end of this presentation. Now, the reason that I wanted to write this paper and make this video was that within the sports and exercise medicine world, a lot of research has been done around dynamic knee valgus and its linked to significant knee injuries such as ACL ruptures. And because of this reported link, a lot of people will be using clinical screening tests to try and identify players who may have dynamic knee valgus and therefore be at risk of significant knee injuries. Measurement accuracy is therefore a fundamental issue in sports injury screening. However, when completing my PhD, I had to spend some time in a clinical Gait lab to get trained up in 3D motion capture, and I was surprised to find there was a difference in the way in which dynamic knee valgus was interpreted in clinical Gait analysis compared to sports and exercise medicine. I'll talk a bit more about this in the next couple of slides. Now, before I go any further, I just want to talk a little bit more around motion capture. Some of you may be familiar with motion capture from working in sports and exercise medicine labs, but for most people you will have come across this in things such as movies where they use a lot of CGI, or video games such as FIFA. In order to capture someone's movement in 3D, it requires placement of some markers on the skin to define segments, for example the thigh. And when we place these markers on people's skin, we make some assumptions. First, that the segments are rigid and that they don't deform. This means that the markers do not move with respect to the underlying bone. And secondly, we also assume that these markers have a specific orientation with respect to the joint centers and the axes. This therefore allows anatomical features to be located and orientated reliably from an external marker set. So for example, in this picture you can see that we've got some markers on this person's pelvis, and based on the location of those markers we can use some mathematical equations to try and find the hip joint center. I also just wanted to make a note about the knee joint. In terms of the physiological movements available, we are told that the knee joint has got 2 degrees of freedom. So it's got a large amount of physiological flexion and extension, and it's got a small amount of physiological rotation, which helps with the locking mechanism of the knee. So really there shouldn't be a massive amount, if any, ab and adduction at the knee joint. So it seems that there's a discord between what we are told anatomically the knee should do and what people are trying to measure in sports and exercise medicine. So for clarity, when we talk about flexion and extension, we're talking about the movement of the tibia relative to the femur in the sagittal plane. And when we talk about ab and adduction or valgus varus at the knee, we are talking about the movement of the tibia relative to the femur in the coronal plane. Now, I do accept that there are people who have static knee valgus varus, but we're not really expecting their knee to move in the same way that your knee would flex and extend in the sagittal plane, that the knee would do the same in the valgus varus movement in the coronal plane, unless they've got a significant amount of knee injury or they've got a lot of congenital laxity. Going back to one of my previous points, one of the assumptions we make when using external markers on the skin is that joint centers and axes can be accurately located from these external marker sets. So for example, in this case, we'd place a mark on the lateral epicondyle of the knee, and from this we can identify the orientation of the knee flexion extension axis. However, if marker placement is suboptimal or wrong, this can result in the knee axis being misaligned. This then leads us into the difference between the way in which these values for dynamic knee valgus are interpreted in sports and exercise medicine and clinical Gait labs. In clinical Gait analysis, dynamic knee valgus is used as an ad hoc quality control measure to see if the marker placement or orientation of the knee axis has been completed correctly. Whereas in some of the sports and exercise studies that I've read, they use this as an absolute value to look at the relationship of the tibia relative to the femur during tasks. And where we see this in clinical Gait analysis is you can see in the swing phase of Gait, where you've got a large amount of knee flexion, we can also see that you get an increase in the amount of abduction. And we call this phenomenon crosstalk. So the movement that's occurring in one plane is lost or reflected in another plane. Now obviously during Gait, when the knee is going through swing, it isn't truly ab and adducting. It just means that the knee axis alignment hasn't been correct. And so for this study, our hypotheses were that the fundamental mechanism responsible for knee valgus varus artifact, or dynamic knee valgus, was suboptimal alignment of the mediolateral knee axis, resulting in crosstalk. We also hypothesized that if we used larger ranges of movement for calibration, this would improve the orientation of the knee flexion extension axis, and this would decrease the valgus varus artifact. The idea being we could provide people with some functional calibration techniques that would make their readings more accurate. Now obviously, as a part of these functional calibration techniques, the larger the range of movement, the more information the mathematical equations have got to try and accurately locate the joint center and the knee axis alignment. And so we used data from 24 male footballers, which were collected as a part of a prospective observational longitudinal study, and we put some retroreflective markers on them according to the conventional Gait model, and we used some additional markers to try and prevent markers dropping in and out during the tasks on the pelvis, and we used an additional medial condyle marker to orientate the knee axis. And so what you can see, the image on the left is the marker set that was used from the conventional Gait model, and we use the same external marker set for the activities of walking, a squat, and a hurdle step. So the conventional Gait model was our static calibration technique, and what that means is we put the markers on the person, you take a capture of them standing still, and from this you can calculate the knee flexion extension axis. We then compared this to the modified DynaCAD, which was the constrained, so we used a smaller range of movement from 20 to 90 degrees, and an unconstrained, which used the full range of movement. And theoretically, what should happen with our results is that the unconstrained should produce higher flexion extension values and lower dynamic knee valgus varus values. And so in terms of methodology, we took the static calibration from the conventional Gait model, and we applied this to the activities of walking, squatting, and a hurdle step. We then took the modified DynaCAD method, so for example we took the walking activity and we used the functional activity of walking and applied it to the activity of walking itself. We then applied this to the activity of a squat, and we then applied the same calibration offset to the hurdle step. We then did another series of calibration where we took the offset values that were calculated from the squat, and this was seen as a loaded flexion and extension task, and we applied this offset or calibration method to the activities of walking, to the activities of the squat itself, and to the activities of a hurdle step. Finally, what we then did is we took the activities of the hurdle step, which was viewed as an unloaded flexion and extension task, and we applied this to the activities of walking, to the activity of the squat, and to the activities of the hurdle step. And so when investigating our sagittal plane kinematics, our knee flexion extension values, there was a very small difference of only about 1 to 2 degrees between either calibration method used or activity on which it was based. However, when we look at the coronal plane kinematics of the knee, so our dynamic knee valgus varus, we can see that there is a difference. And this difference is highlighted quite well in this example. So what we have on the y-axis is the experimental test, so the activities themselves, and then what we have on the x-axis is the calibration method used, so the offsets derived from each activity were then applied to these experimental tests on the y-axis. And what we can see is that for the activity of gait, when we apply the offset calculated from the hurdle step trial calibration, this actually increases the knee varus angle. And so the DynaCAD method hasn't improved our dynamic knee valgus varus angle here. However, when the calibration activity was a hurdle step and was applied to the hurdle step itself, we can see that the DynaCAD methods improve this artifactual dynamic knee valgus varus angle. And so in summary, the differences between valgus varus angles range from approximately 4 to 14 degrees. And this is larger than some of the differences that have been identified as being clinically important for things such as patellofemoral joint pain or even identifying players at risk of ACL rupture. To achieve the best result for alignment of the mediolateral knee axis, either the modified DynaCAD calibration method should be used, however it should be based on the movement to be analyzed. The variations in the rotational offsets between calibration methods indicates that crosstalk is unlikely to account for all the variations that we observed. This means that if it was purely misalignment of the knee axis, it wouldn't matter on which activity you based it on, it would still result in determining the same amount of offset that needs to be added to correct the knee axis alignment, and this should be consistent and therefore be applicable to all activities. What we found is that soft tissue artifact probably associated with increased muscle volume of the players and movements over larger ranges of movements may influence some of the kinematic results that were observed. It's also important to note that a lot of these models and methods used to measure movement were originally designed for use in Gait. Now, Gait lends itself quite well to motion analysis because it's a series of repeated reference tasks that's usually performed at a self-selected walking speed. And therefore, the activities that people try and evaluate in sports-induced screening directly challenge some of these assumptions around the models and procedures that are used for data capture. And so in our discussion section, we identified that our study results disprove both of our initial hypotheses. We found that soft tissue artifact, or the amount of marker movement as a result of skin and muscle moving, was also found to affect valgus varus angles. Therefore, suboptimal alignment of the mediolateral knee axis wasn't the primary mechanism for the valgus varus artifact. We also found that calibration of the knee mediolateral axis using larger flexion extension ranges didn't result in decreased valgus varus artifact all the time. As I mentioned earlier, if this was true, then optimization of the axis based on the hurdle, step or squat should have decreased the valgus varus angles in Gait. However, we showed that that wasn't the case. This therefore has some eminent clinical implications. What we found is that not every calibration method and movement activity can be advocated for all activities, and so the use of a single functional calibration activity for the analysis of multiple complex movements is questionable. If you'd like to read more about the paper in full, there should be a link below, or you can take a photo of this QR code and it should take you to the paper. Thank you for listening.